Will come to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. Since we are working in a virtual format today, I'd like to go over a few housekeeping items before I proceed. First, if you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so it can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee policy that members will remain muted when not recognized, just like turning your microphone on and off during a hearing in person. This is out of courtesy to all members on this committee and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything that you say. If you wish to be recognized, please raise your hand using the Zoom raise hand function, unmute your microphone, and ask to be recognized. In order to ensure everything members say is captured on the live stream of this hearing, I ask that members pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearing@mail.house.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of seniority for questioning witnesses. This makes it easier for me to make sure all members participating have an opportunity to be recognized. Does any member have a question about the conduct of the hearing with members participating remotely? Seeing none, I now recognize myself for an opening statement. Good morning. I should say good afternoon. Thank you all for joining us here today. I'm proud that the first subcommittee on health hearing held this Congress will discuss women veterans during Women's History Month. I want to begin by taking a moment of silence to remember Private Levine Johnson, Lance Corporal Maria Lauterbach, Specialists Vanessa Gillian, Airman First Class Natasha Apashian, and other service women who were murdered by men they served with. Thank you. Today, our work focuses on achieving equity for women veterans, including ensuring America's women warriors are safe and welcomed when accessing resources they earned and deserve. Like Congress, I launched the Women's Veterans Task Force to ensure equity and access to health care benefits and economic opportunity for women veterans. The 85-member bipartisan task force held more than 20 hearings and roundtables and passing dozens of bills. We worked in a bipartisan manner to pass the Deborah Sampson Act, which became law in January. This legislation supporting women veterans is a key step to meeting the needs and raising the visibility of America's 2 million living women veterans. The bill honors Deborah Sampson's service and also acknowledges the persistence of women veterans such as Harriet Tubman, the first American woman known to lead troops in combat, and Hazel Yang Lee, the first Chinese-American pilot in the U.S. military. When I speak to women veterans and women still serving in the armed forces, it is clear that every single one of them is a trailblazer. It is thanks to their perseverance that the Deborah Sampson Act not only became law, but that we are sitting here today to discuss the work that lies ahead. On the issues we still hear about consistently is coverage for in vitro fertilization. And yesterday I introduced the Veterans Infertility Treatment Act of 2021, which makes infertility treatment for veterans and their partners part of healthcare available at VA. Today's hearing will explore the work we still must do. This includes rebuilding trust with women veterans, health equity for minority women veterans, the early stages of the implementation of the Deborah Sampson Act, and legislative work that lies ahead for addressing reproductive health and mental health. President Biden, Vice President Harris, and Secretary McDonough have already set a tone of prioritizing diversity, equity, inclusion, and access for our nation's veterans, and have elevated eliminating sexual and gender-based violence in the military and at VA as a top priority. I also applaud the inclusion of VA in the 90-day independent review commission on eliminating sexual harassment and sexual assault in the military. As President Biden said, this is an all-hands-on-deck effort. The work of the Women's Veterans Task Force made clear that there are many areas where VA has resources and research that the DoD does not, and improved coordination between the two departments is crucial to supporting survivors of military sexual trauma. No service member should perpetuate or experience the fratitude of military sexual trauma, nor be subject to the bureaucratic violence of retaliation for reporting. It contradicts the value of leave no one behind. Last year, VA provided health care to more than 230,000 veterans, both women and men, who were sexually assaulted or sexually harassed while serving. It is our mission here on the committee to ensure no veteran is left behind, and today we will say loudly and clearly that no women veteran is left behind. That means taking an intersectional approach to our work. Women of color serve in disproportionately higher rates compared to their percentage in the overall population. Soon, more than half of all women veterans will be women of color. In addition, a large portion of women veterans are LGBTQ, and many served under Don't Ask, Don't Tell, and other discriminatory practices. Today, every woman veteran is a proud, visible veteran. I look forward to continuing our work to ensure that it is always the case. This afternoon, we will hear from the VA, VSOs, and community-based organizations to take a holistic view of the work that lies ahead of us. I'm looking forward to each and every testimony. With that, I'd like to recognize General Bergman for 5 minutes for any opening remarks he may wish to make. General.
Thank you, Chairwoman Brownlee. I spent 40 years of my life in the uniform of a Marine. Every year, every day of that was a privilege. But I know from experience that military service is just one aspect of a veteran's life. The work this subcommittee does is critical to ensuring that our nation's veterans are taken care of so they can lead long, full, and healthy civilian lives. That is why I'm proud to be the lead Republican on the Subcommittee on Health for the 117th Congress. We have a lot of work ahead of us, particularly given the havoc that COVID-19 continues to wreak on our country and her veterans. I look forward to starting that recovery effort today with you, Chairwoman Brownlee. I hope that we can one day soon sit alongside one another in our own hearing room. Until then, it is a pleasure to join you, our subcommittee colleagues, and today's witnesses who are here virtually for our first subcommittee hearing of the Congress. The topic of today's hearing is one that is near and dear to all of us: improving care, benefits, and services for women veterans. Women are volunteering for the armed forces in record numbers. When they separate from service, they are seeking care from the Department of Veterans Affairs in record numbers as well. The passage of the Deborah Sampson Act last Congress was a milestone moment in this committee's quest to make sure that they are all greeted by a VA healthcare system that is ready, willing, and able to meet their needs and assure their safety and well-being. Today is our first opportunity since the Deborah Sampson Act became law to hear how VA will implement it. The devil is in the details, as they say. I hope the VA is approaching implementation with the urgency that women veterans deserve. And having spent 4 years on Veterans Affairs Committee already, if you've ever testified before, at least O and I before, you understand that we say sense of urgency, we mean sense of urgency. Not next year, not next week, but today. Today's hearing is also our first opportunity to consider what further actions we can take this Congress to build on the momentum of the Deborah Sampson Act. Like everyone else, I am concerned about how women veterans are faring during this pandemic. Mental health and suicide prevention in particular are two of my highest priorities. Veteran women are 2.2 times more likely to die by suicide than non-veteran women. We know that economic instability is a key risk factor for suicide. With unemployment rate for veteran women outpacing unemployment rate for veteran men, particularly among younger veteran women, I want to make sure that the VA is prioritizing support for women who have lost their jobs and are doing everything possible to help them get back on their feet. I also want to make sure that VA is taking every appropriate action to get women veterans vaccinated against COVID-19 and re-engaged in care within the VA healthcare system and in the community. I'm grateful to our witnesses today for their service in uniform and out, and for being here today to lend their expertise. I look forward to listening to all of your testimony. And with that, I yield back.
Thank you, General Bergman, and I too look forward to working with you on this committee together. So we are also joined by the chairman of the full committee, Chairman Takano. Mr. Chairman, you are recognized for 5 minutes for opening remarks.
Thank you, Chairwoman Brownlee. Good afternoon. I'm pleased to join you all this afternoon for the first Women Veterans focused hearing of the 117th Congress. Chairwoman Brownlee, because of your leadership of the Women Veterans Task Force and the 116th Congress, addressing the needs of women veterans was central to the committee's work. And I'm pleased that this will continue to remain a committee priority this Congress. These efforts resulted in our bill, the Deborah Sampson Act, becoming law. This landmark legislation is the most comprehensive women veterans, gosh, I lost my place for a second here. Let's see if I can pull it back up. Bear with me for a moment. Where'd it go? Okay. This landmark legislation is the most comprehensive women veterans legislation in more than a decade. And Speaker Pelosi called it the crown jewel of the veterans legislative package we passed in December. Chairwoman Brownlee, I'll continue to look to your leadership in addressing the needs of women veterans this Congress. Supporting women veterans, creating a welcoming VA, and building equity for veterans and effective legislative implementation are among my top priorities. All women deserve to feel safe while accessing high quality VA care, and we must continue to eradicate sexual harassment and assault and other forms of unacceptable behavior at VA facilities. And while the committee is optimistic regarding changes currently underway at VA to address this issue under the new administration, we will remain vigilant as the Deborah Sampson Act moves toward implementation. Now, it is fitting that this hearing is being held during Women's History Month. Prior to COVID-19 limited our travel, I had planned to make a visit to England in commemoration of the 75th anniversary of World War II to pay my respects to the 6,888th Central Postal Battalion, led by Major Charity Adams. It was the only all-Black, all-woman battalion overseas during World War II. Last week, I also had the honor of interviewing retired Navy Master Chief Octavia Harris for the Library of Congress's Veteran History Project. She was one of the first women to serve on a warship and served nearly her entire career under the Don't Ask, Don't Tell policy. Something that she shared with me during that interview resonates with me still. She said, quote, "I had 3 strikes against me. I was a woman, I was Black, and I spent 30 years in a closet," end quote. She faced enormous obstacles just to put her uniform on and go to work every day. In spite of those barriers, she rose to the highest enlisted rank in the Navy. By the way, I encourage all members of the committee to get involved with the Library of Congress's Veterans History Project. It's available to all of you, and there's even special rooms at the Library of Congress for you to interview veterans once we open up fully again. Now, on the House Committee on Veterans Affairs, we will work to eliminate barriers for all veterans after they have served. And I'm pleased that Ranking Member Bost is in attendance today to demonstrate that achieving equity for veterans is truly a bipartisan concern. I look forward to hearing from today's witnesses and yield back the balance of my time.
Thank you, Chairman Takano. And finally, we are also joined by Ranking Member of the full committee, Mr. Bost. Mr. Bost, you are recognized for 5 minutes for opening remarks.
Thank you, Chairwoman Brownlee and Ranking Member Berkman and Chairman Takano. I appreciate the opportunity to join you all today. This hearing addresses a topic that is a high priority of mine: strengthening services for women veterans. It should go without saying that women are vital and irreplaceable part of our military. I'm very proud to work with this committee and did last Congress to better serve them as veterans. The enhancement of the Deborah Sampson Act was a notable achievement. It was a result in significant improvements for generations of women warriors to come. But contrary to the schoolhouse rock, may have you believe that getting a bill signed into law is the first step. Understand, only the first step. The second is to make sure that every way possible, and it's a little bit harder, to make sure the ideas that were put forth in the legislation are put into practice the way they were passed. So I hope today's hearing will be the first of many on how the Deborah Sampson Act is living up to the promises that were made. Women veterans are counting on us to get this right. We cannot let them down. We also mustn't take our eyes off the ball when considering how else to support the growing number of women veterans who serve. I'm particularly concerned about the impact of COVID-19 has had on women veterans' health and economic security. According to the most recent data from the Bureau of Labor Statistics, the overall unemployment rate for female veterans is 6.1 compared to 5.4 for male veterans. That is even worse. That's worse, bad enough, but the unemployment rate for post 9/11 women veterans was a staggering 9% in February. Last February, before the pandemic, it was 2.8%. We must do everything we can to help these women veterans who have lost jobs over the last year to get back on their feet and re-enter the workforce. I hope that in this hearing, we will have, I hope that we'll have a committee hearing on this very soon as well. In the meantime, I'm grateful for the continued leadership of Chairman Brownlee and General Berkman, the new subcommittee on health ranking member, and I look forward for today's hearing and listening to the witnesses. And with that, Madam Chair, I yield back.
Thank you, Ranking Member Bost. With that, let me introduce our first panel from VA's Veterans Health Administration. Our witnesses are Dr. Cameron Matthews, Assistant Undersecretary for Health for Clinical Services, Dr. Patty Hayes, Chief Officer, Women's Health Services, and Ms. Leila Jackson, Senior Strategist for VHA Assault and Harassment and Prevention Office. I will remind our witnesses to please pause for 2 to 3 seconds before speaking so that the recording will capture all of your words, and please remember to do so when answering members' questions. Your written statement in full will be included in the hearing record without objection. So with that, I now recognize Dr. Matthews for 5 minutes. Welcome.
Good afternoon, Chairwoman Brownlee, Ranking Member Bergman, and distinguished members of the subcommittee. I also want to acknowledge Chairman Takano and Ranking Member, both who are also with us today. I appreciate the opportunity to discuss how VA provides services to our women veterans and what we have done to assure that our programs respond to their needs. I'm accompanied again today by Dr. Patricia Hayes, Chief Officer of Women's Health, and Ms. Layla Jackson, Senior Strategist of our Assault and Harassment Prevention Office. Because of the increase of women service members in our nation, women seeking out VA healthcare are increasing and placing new demands for the better on VA's healthcare system. More women are choosing VA for their healthcare than ever before, with women accounting for over 30% of the increase in veterans enrolled over the past 5 years. The number of women veterans using VA services has tripled since 2001. To address the growing number of women veterans who are eligible for healthcare, VA is strategically enhancing services and access by investing $75 million in FY 2021 for new equipment and personnel. Specifically, funds will be used to hire women's health personnel, such as primary care providers, gynecologists, care coordinators, and mental health providers for women. VA is proud to report that every VHA healthcare system across the United States now has a full-time women veterans program manager tasked with advocating for the healthcare needs of women veterans using that facility. Many residencies in women's health with didactic and practicum components have been disseminated system-wide to enhance clinician proficiency. Since 2008, over 7,700 healthcare providers and nurses have been trained in local and national programs. Under a new collaboration with the Office of Rural Health, a pathway for accelerating access to women's health training for rural primary care providers has been established. In addition, numerous initiatives have been launched to improve access to state-of-the-art reproductive health services, mental health services, emergency services for women veterans, and others have focused on enhancing care coordination through technological innovations such as cancer registries and mobile applications. Additionally, to provide the highest quality of care to women veterans, VA offers them assignments to trained and experienced designated women's health primary care providers. The providers can furnish general primary care and gender-specific primary care in the context of a longitudinal patient-provider relationship. National VA satisfaction and quality data indicate that women who are assigned to women's health primary care providers have higher satisfaction and higher quality of gender-specific care than those assigned to other providers. VHA is making continuous efforts to create a welcoming, respectful, and safe environment for all veterans, including its aggressive efforts to implement Section 5303 of the Veteran Healthcare and Benefits Improvement Act, or the Deborah Sampson Act. In addition, the VA Sexual Harassment Program Integration Governance Council serves as an oversight and integrator for sharing of information in key programmatic milestones regarding a cohesive sexual harassment prevention and response program. Over the last year, VHA has improved data collection and analysis on reports on sexual assault in order to not only improve reporting, but to also identify and address gaps in VA processes. In addition, VA rolled out bystander intervention training for staff during late fall of 2020. The goals of the bystander intervention training is for staff to develop skills to recognize behavior that is aggressive and be empowered to act. To date, VHA has conducted 44 90-minute sessions to employees and 3 train-the-trainer sessions. VA continues to create a regular communication drumbeat to promote a harassment-free VA and to underscore that VA has zero tolerance for harassment and sexual assault. During National Domestic Violence Awareness Month, VA successfully launched White Ribbon VA. White Ribbon VA is a national call to action for employees, veterans, and our VA partners to make a commitment to never excuse, remain silent, or commit sexual harassment, sexual assault, or domestic violence against others. In conclusion, VA continues to make significant strides in enhancing the language, practice, and culture of the department to be more inclusive of women veterans. These gains would not have been possible without consistent congressional commitment in the form of both attention and financial resources. It is critical that we continue to move forward with implementing the Veterans Healthcare and Benefits Improvement Act of 2020 so that we maintain the current momentum and preserve the gains made thus far. Your continued support is essential to providing high quality care to our veterans and their families. Thank you for your time. My colleagues and I are ready to answer your questions.
Thank you very much for that. And I forgot that we're having two panels today. So again, just a reminder to my colleagues that members should pause for 2 to 3 seconds before speaking so that everything is captured. So I now recognize myself for 5 minutes for questions. So the first question, Dr. Matthews, is to you. I just want you to be on record giving me your full commitment to fully implement the Deborah Sampson Act.
Apologies. You have our full commitment to implement the Deborah Sampson Act.
Thank you very much. And second question, Dr. Matthews, within the Act, the Deborah Sampson Act, it requires the creation of VSO working groups to be active participants in VA's effort to end sexual harassment and sexual assault. So I want to know what efforts are currently underway. And just as a heads up, I'm going to be asking the same question to the VSOs on the second panel.
Great. I'll actually defer that question to Ms. Jackson. Could you speak to the working groups?
Yes, ma'am. Good afternoon, ma'am. We are actually anticipating making an announcement very shortly, inviting our VSOs, the tribal, state, and local agencies to participate in the Secretary's work group pertaining to 5303. So we're excited about that, but we want to work beyond just, the working group, but we are going to be doing that.
Very good. Thank you so much. So Dr. Matthews and Dr. Hayes, as you know, the women veteran population is rapidly growing, and a recent congressional mandated report confirmed that it's not likely to change anytime soon. The women veteran population is projected to grow from 10% now to 16% of the veteran population by 2040. Considering that younger women veterans leaving the military now have a higher VHA utilization rate. So that makes the demand actually on VHA even greater. And in your testimony, Dr. Matthews, you stated that every VHA facility has a full-time women veteran program manager. You also went on to say a women's mental health champion at every VA facility. What you didn't mention is that every VA facility should have an MST coordinator, a peer support specialist, and an intimate partner violence coordinator, and a maternity care coordinator. So in Deborah Sampson, one of the sections of Deborah Sampson is that GAO will be required to report on VA's efforts and adequacy of these positions to provide these supportive services to women vets. So I guess my question to you is, how do you think VHA will score in that report?
Well, I don't think that we'll score as highly as we would like yet. I do think that a lot of the additional resources that Congress has provided us in order to fully implement the act will definitely get us there. Dr. Hayes, I'd love for you to speak to the staffing forward motion that we have.
Certainly, thank you for the question. We, even before the passage of the act, had devoted $40 million to the field in September to begin to address the shortages and gaps that were previously identified in staffing. That particular initiative was over 413 staff with both providers, nurses, and care coordinators. I agree that we continue to audit regularly and to make strides towards filling some of these care coordination positions and our provider position. So with the 30% increase in veterans being women, we're continuing to push on the gaps. So not only do we put out 40 million in October, but with the additional 35 million plus up, we are putting out an additional request for facilities to ask for staffing and equipment. That's going out actually next week. We'd already announced it, and we hope to supply those for an ongoing 3-year recurring staffing position to make sure that we don't have these kind of recurring gaps. But we expect to be challenged continuously to make sure, because of the growth in the population. So we're on it, but we have a lot of work to continue to do.
Thank you, Ms. Hayes. And I will just conclude by saying that, our expectation certainly is not to have one person at a VA facility providing all of those functions, that we want to see more full-time MST coordinators, more full-time peer support specialists, et cetera. So we're going to keep a razor sharp focus on that in any way we can be helpful. We want to. And with that, I now recognize Ranking Member Bergman for 5 minutes of questioning.
Thanks, Chairwoman Brownlee. Dr. Matthews, how has utilization of VA care among women veterans been impacted by COVID-19, both by the virus itself and deferred care, potential mental health effects, and economic stress that the COVID has caused?
Yeah, thank you so much, sir, for that question. This has definitely been something that's quite concerning, not just within the VA, but across the entire healthcare sector. And we're definitely participating in a lot of kind of whole of government responses in trying to assure that there's appropriate resources there. I think we are poised more than any other integrated health system in order to really address a lot of those additional non-clinical, but obviously impacting clinical need concerns that you cited through different screening methods that we have, especially around food insecurity, housing insecurity. What I unfortunately can't share with you are exact numbers at this time of what the impacts are, but I am and have publicly stated definitely concerned about deferred care as a primary care doc. There are decreased numbers nationwide, VA as well as private, of patients coming into the emergency room, of seeing their primary care doc, of coming in for preventive services. I think this is a message that we all need to share quite loudly, that to not continue to defer care, that it is safe to come into VA, into your hospital, and get these necessary services. I'm definitely equally concerned, and I do believe, though, that VA is well suited to respond to those needs when they become apparent.
I think the time is right to look for trends, collect data, because just because we have the COVID pandemic to deal with now doesn't mean there's not going to be something similar, not necessarily a pandemic, but that's going to cause disruption in services. So good data now and is going to help us long term. Dr. Matthews, also, we know that VA research, from VA research, that approximately 25% of women veterans report being harassed by male veterans on VA grounds. While VA works to eliminate harassment from its facilities, I want to ensure that women are empowered to seek care where they feel safest and most comfortable, which may be in the community, given the rates of harassment that occur in VA. However, does the utilization of community care compare? How does it compare between veteran men and veteran women? Veteran women report feeling unsafe at VA. Is that alone sufficient reason for the VA to refer her to the community? Yes or no? How does that work?
Yeah, currently it can be a decision made between the woman veteran's primary care provider and herself to really get an assessment of what is within her best medical interest as part of our eligibility for community care. So if indeed this is impacting, of course, her mental health stability, her larger well-being, there is room for a referral to the community. We'll have to get back to you on actual statistics of how it divides, unless Dr. Hayes, you're able to speak to kind of ratios of women accessing community care or not. But given that maternity care is not offered within the VA, and particularly infertility services office, I would say there's a larger proportion. But Dr. Hayes, I don't know if you have more specific numbers.
The amount of community care for women is slightly more than for men, but as you point out, we don't disaggregate that by folks who have sexual trauma histories or anxiety due to coming to medical facilities, but we would allow them to go out if that were the issue. Our stronger issue is to fix VA. As you know, we've talked about trying to do that.
Yeah, thank you. Dr. Matthews, do we have enough research today to say definitely whether or not, let's say in the positive, there are higher rates of infertility among those women who have served?
At this point, no, it's still insufficient evidence around infertility of women who have been deployed, but it's definitely a very prioritized topic of interest within our post-deployment research teams. We are quite eager and have actually increased attention within our registries currently. And several studies ongoing, which they actually described yesterday, with some data becoming more available in the coming months. But unfortunately, no evidence that's ultimately conclusive at this time. Dr. Hayes, anything to add to that?
No, I think you captured what we have at this point.
Okay, I see my time is up, Chairwoman Brownlee, and I yield back.
Thank you, General. And I now recognize Chairman Takano for 5 minutes of questioning.
Thank you, Chairwoman Brownlee. My first question is for Dr. Matthews of the VA. Dr. Matthews, subcommittee staff have also heard about some concerns from trans men who, when accessing gynecological care in the community care network, have had their identities questioned openly in waiting rooms. How is VA ensuring that all veterans who need access to obstetrics and gynecology are being sent to providers that treat them respectfully?
I think thank you for that question. I think that's of significant concern and one where I would want to make sure that provider is immediately addressed. I think we could definitely expand the additional competency around transgender health within the community care network. There is, of course, as you know, broader military competence training and more military specific conditions, mainly more MST and PTSD and TBI. Around transgender health, I do think, as throughout the private sector, I think there needs to be really a plus up of how providers are able to handle that. We, of course, are ready to respond when, of course, those providers are pointed out. But that's something we would need to take on to really address, to assure that we're referring those veterans to the appropriate provider.
Dr. Matthews, thank you for that answer. VA currently does not have any inpatient psychiatric units separated by gender. Inpatient mental wards can be very threatening places for women veterans when male patients are co-located. Do you have any plans to separate inpatient mental health services by gender? And if not, why not? If it is impractical for VA, would you consider this as a basis for referring to women-only inpatient mental health programs in the community?
Yeah.
If I could address that. In our inpatient mental health units, we do have a couple of inpatient mental health units, one in Houston that is specifically for serious mental illness conditions. We also have a couple of places that have, while in the same technical inpatient mental health unit, they have a separate wing for women and separate wings for men. And so, but we do not recognize that we're in the process of evaluating what is needed for our women to be able to have the right kind of mental health treatments in a safe environment. It also is very difficult to find gender separate units in the community. I think people sometimes believe that that's possible, but it actually is fairly rare. The issue is safety and changing the culture. We've done some unique trainings of staff in our inpatient mental health units so that the staff intervene with the kinds of behaviors that are most frightening by the male veterans towards female veterans and towards trans veterans in the inpatient units. So you point out a very important problem, but the solution is not as straightforward as it sometimes might seem. But we do send women from wherever they are to the community in Houston for women-only intensive psychiatric care.
Thank you for that information, Ms. Hayes. I hadn't realized that it was very rare in the community as well. So I appreciate that. Women veterans who use VA are at a median age of 51, 14 years younger than the median age for men. In addition, a large women's veterans population means more women veterans with spinal cord and other catastrophic injuries. How is VA addressing the current needs of women veterans who need long-term care And how is VA planning for a silver tsunami? I think a favorite topic of the chairwoman among women veterans.
I think this is a question that I know Dr. Stone is feverishly giving attention to as far as planning for that silver tsunami. You are right. The increasing age and number of veterans who would need long-term care is something that our current infrastructure, as far as number of beds, would not necessarily address. So we're in the midst of developing strategy currently through our geriatrics and extended care office. And yes, the needs of all of our different demographics would need to be addressed within those plans. But we're in those conversations now, and definitely happy to keep you in the loop as those develop. It's a complicated question given when you look at the volume of aging veterans, you may need a certain number of beds in a time frame, but then after that time frame, those beds might actually sit empty. So how do we judge needs? How do we work perhaps with community partners? How do we look at different infrastructure opportunities so that we're not over planning or under planning for any given population of veterans?
Thank you. Thank you. I'm over time, and Chairwoman Brownlee, I certainly compliment you on your interest and priority on the silver tsunami, and want to let you know that my recent conversations with Paralyzed Veterans of America, we really face a challenge in meeting the needs of specialized long-term care as well. I yield back.
Thank you so much, Mr. Chairman. And I now recognize Ranking Member Bose for 5 minutes of questioning.
Thank you, Chairwoman Brownlee. Dr. Matthews, last week, President signed the American Rescue Plan, and he provided the VA with additional $17 billion in revenue. As Chief Medical Officer for the Veterans Health Administration, were you involved in the developing need fund to ask for those funds?
Yes, I definitely was.
All right. Are you involved now in determining where they will be used?
Yes.
Okay. Do you know how much of that funding will be devoted to women's health or gender-specific services, if any?
Off the top of my head, I apologize, sir. I'm not tracking the different expenditures at this point. I do know we have a separate amount focused, particularly with a lot of what we're talking about with the pandemic and economic concerns for homelessness programs. That I'm definitely tracking, but nothing straight line solely for women veterans in general. We are looking to distribute those funds across the nation for different needs. But I will definitely get back to you with some further numbers.
That'd be great. Thank you. Dr. Matthews, also, and this is just a yes or no answer. We will like for the VA to commit in providing the committee staff with briefings on at least a bi-monthly basis on how the implementation is going of the Deborah Sampson Act. Can we get that commitment that you can do that on a bi-monthly basis?
Yes, you definitely can. Yeah.
Okay. How many women veterans have been vaccinated against COVID-19 so far? Do we know that?
Oh, I apologize. I don't remember that off the top of my head. I have that number. If you don't mind, sir, I'll take that for the record. I apologize. A lot of papers in front of me, and I'm not remembering the flat number. I apologize.
So along that line, and because not only for the VA, but we've been having this whenever the vaccine is being distributed around this nation, whether it's healthcare providers and everybody else, are you seeing a particular vaccine hesitation or other barriers to the vaccine when women veterans are trying to be encouraged to take the vaccine? Or are there certain ones that saying, I don't really want it?
No, we're not, sir. We're not seeing any difference there from a gender standpoint at all. We do see equal rates of vaccination between both male and women veterans.
That's good to hear, because at our local level on our healthcare providers, when we were first going out, we were, if you got 70%, you had a high number. Most of them were running 50 and 60%, and that was among healthcare workers. So that was vitally important for us to understand. So with that, I will yield back. Those are the questions that I have, and thank you so much, Chairman, and thank you, Dr. Matthews.
Thank you, Ranking Member Bost. And out of courtesy to Congressman Sablon, who is in the Mariana Islands at 4:30 in the morning, we all owe him gratitude for attending this hearing, and he's been awarded with being the first questioner. So Congressmember Sablon.
Oh, wow. Madam Chair, thank you. Thank you very much. Actually, I wish I started at 11 last night and it's now 5:15. But I'm going to I'm going to participate in both panels. But thank you. Dr. Matthews, my district is in the Northern Mariana Islands, so we're the only district without a CBOC. I understand that services are sporadic. We have a fee-based contractor, but
All these people on?
having said that, for regular service for our veterans, in particular, do you have, maybe you don't at the moment and have it with you, but would you share with me, please, how you will address our women veterans here in the Marianas? There is almost 15,000 across the 4 smaller territories of American Samoa. Mrs. Wagon is a member of this committee, sits in there. But just for what your plans are to help women veterans. There was an incident last 2 years ago when actually a couple, both veterans, they came to see me because they were having problems in getting the help they needed from VA here in the Marianas, and it was difficult to talk to them because there were a couple, and the woman, the lady didn't want to talk to us with the husband there, and then the husband, I mean, it was just, but what do you have in terms of services for women veterans to the Marianas? If you could share that with us, please, even at sometime soon, I hope.
Yes, sir. Thank you so much for the question. It is difficult to maintain services there. And yes, we do have a fee basis clinic there. I think one of the pieces that of course we're proud about is the health system for the Pacific Islands definitely does offer the care coordination services that we need, so that when the women veterans do need to go into the community, we can still stay connected to them. We can still assure that we're navigating them to the appropriate providers, and if needed, transporting them to another island if those providers aren't available. But currently, we don't necessarily have additional plans to build additional VA resources there, but we work with each individual veteran to make sure that they're receiving what they need if available there on the island.
Right. No disrespect to you, Dr. Matthews, but sometimes the VA doesn't actually, I mean, it's easier said than done. It's not just because of the problem, it's that your person on the ground here who handles all of these things that's supposed to make this seamless has an attitude that is just impossible to overcome. And despite actually an IG review about how she treats veterans, she's a veteran herself, just been a problem, and it continues to be to this day. But thank you. But when you get a chance, share your plans with us, please. Any plan that you may have. Thank you. Okay. Thank you for what you do, Dr. Matthews. I yield, Madam Chair.
Thank you, Congressman Sablon, and I do hope, Dr. Matthews, that you follow up on what Mr. Sablon is saying. I think it's it's really important, and it's very difficult to serve our veterans so far away, but they have served and sacrificed just like anyone else, and they deserve better. So next, I will call in Congresswoman Rodawagen for 5 minutes of questioning.
Thank you, Chairwoman Brownlee and Ranking Member Bergman, for holding this hearing today to address gender-specific healthcare needs of veterans. I'm sure everyone here agrees that a service member is entitled to a certain standard of care when they return from service, regardless of sex or gender. And I'm grateful for the work this committee has done to address the varied needs of all of our veterans. I'm proud to have supported the Deborah Sampson Act, and now that it has passed, Congress has an obligation to work with VA to ensure that it's carried out. Dr. Matthews, I'm very concerned about the impact delays in care over the last year will have on cancer diagnoses and deaths moving forward, given the importance of early detection and treatment. My question is threefold. First, how is VA tracking deferred mammography and other preventative care appointments for women veterans over the last year? Second, what steps is VA taking to encourage women to safely re-engage in care? And third, how can Congress support those efforts? Dr.
Thank you so much for those questions. This has been a large concern of mine, particularly when you think about mammography. Unfortunately, there across the board, there tends to be a need to really outreach to patients in general about that. And so then when you add in the concerns of the last year, that's a force multiplier, definitely. We are tracking those women for which, of course, we have data on with regard to their last mammography and providing that outreach locally through their PAC teams in order to really try to motivate them and to assure them of safety, to direct them either to one of our own mammography centers or to the community. We've actually instituted what we call a preventive health inventory. Within the PAC team, there's this new note that allows us to track for each veteran, but particularly for women veterans, it does reflect, of course, mammography in addition to colon cancer screening, in addition to other screenings, so that we can make sure and really share that data all the way up on a management level, even nationally, about where there are gaps in mammography and really make sure that we're holding local leadership accountable to make sure that outreach is occurring. How can Congress support? I would say in the same fashion, continue to ask us exactly that question. I think hold us to task. This is of great importance as we really do assure that the deferrals of care over the last year, exactly as you said, doesn't lead to increased mortality or even morbidity in the short term. But thank you for that question. Equal priority for us as well.
Thank you, Dr. Matthews. In his opening, Ranking Member Bost referenced the higher unemployment rate for women veterans compared to male veterans. What connection, if any, is there between a veteran's employment status and their reliance on VA care? How do you expect the increased women veteran unemployment rate will impact the demand for and types of care that veterans are looking for? Dr. Matthews.
I expect that to have an unfortunately negative impact. As we know, the financial stressors of being unemployed, how that can threaten not only your housing situation, but perhaps childcare, again, food insecurity. We are really, unfortunately, bracing for the need to support women veterans in particular through our homeless program office, different opportunities through SSVF and other programs. I think one of our strengths is that we are regularly focused on this. As an integrated health system, we are screening for these issues. This is not just taking care of what clinical problem you're faced with as you come in for that day, but we want to understand you as a whole veteran, and we want to understand what circumstances might be impacting your entire well-being, as well as your mental health. Stress of dealing with unemployment and economic crises in general is something that we are particularly concerned about, as that may impact mental illness in general and even contemplation of suicide. So we are tracking this and really looking to bolster how we are performing that screening and how we are supporting different services. Very grateful under the Veterans Healthcare and Benefits Improvement Act that we are looking at broader screening responsibilities as far as offering examinations, primary care examinations. That's where these conversations occur. So we are in the formulation stages of a plan of outreach to every veteran out there so that we can assure that their needs are being met.
Thank you, Madam Chairwoman. Yield back.
Thank you, Ms. Radawagan. And now we'll recognize Mr. Mervan for 5 minutes. Welcome as a new member of the committee.
Thank you, Chairwoman. I appreciate this opportunity. Dr. Matthews, you state in your testimony that the VA is on the forefront of information technology for women's health. I understand that electronic health records modernization process will result in an improved VA ability to track breast and reproductive health care, and that VA already analyzes quality performance measures by gender. Could you provide additional examples of the VA being on the forefront of information technology for women's health? And additionally, are you confident that the electronic health records modernization process will result in improved health outcomes for women veterans across the board? If not, what else can be done to ensure that it does?
Great question, sir. Great question. From a technology standpoint, I think, we can't neglect to really recognize the strength of the VA health system as far as telehealth. So it doesn't go so far as, the fanciness of registries or electronic health records, but just our ability to have expanded, more than 1,700% telehealth over the last year. The fact that we have that capacity across a health system, across a national health system is really just incomparable to other health systems. So technologically, I think our ability to connect with women veterans, particularly over the last year when they, again, might have had higher risk of unemployment, might be dealing with childcare issues more likely than male veterans. I think the concept of having broader scale telehealth really does address their needs. I think there's definitely more that we can do and that we'll hope to do, particularly through whole health and through mental health, as far as assuring that we're expanding our residential treatment programs, which did see a bit of a decrease over the last year in utilization. But again, that definitely had to do with the fact that social distancing might have deterred a lot of patients from seeking out group environments. But with that being said, we definitely are at the forefront. With the electronic health record modernization, I have been digging deep into this. This is now in my space as now functional champion as Chief Medical Officer for this deployment. And I have to say, this is not an easy task for any of us. I also have to recognize, at least academically in the private sector, there isn't really evidence that electronic health records improve outcomes. They improve coordination, they improve communication. But as a technology, their goal is, and this blew my mind as well too when I was reading the studies, but it doesn't necessarily improve healthcare outcomes. Our goal, of course, is to prove that wrong. And by having national breast cancer registries and having perhaps in the future working with Cerner, perhaps some AI component to really start to forecast disease, to forecast where we need to go for women veterans and veterans as a whole. That's what I'm eager for. So I hope to come back to you in the future and tell you we have improved health outcomes. But at this point, we're really in the nitty gritty of just dealing with the change management of going to this new system.
Thank you. Well, thank you. Dr. Matthews, I'm appreciative of all the VHA is doing to develop gender-sensitive, evidence-informed mental health services for women veterans. Recognizing as you do that age-adjusted suicide rate for women veterans has been found to be 2.1 times that of the non-veteran women, what technological solutions or innovations is the VHA pursuing to prevent suicide among women veterans?
I think, again, our telehealth expansion is quite necessary in order to reach and provide that access. I think one thing that we were nervous about, you also heard it throughout the private sector as well, as you convert to telehealth, there may be increased hesitance to actually answer certain questions. When we're in a screening capacity, primary care capacity, and you're in a room face-to-face with your provider, you may be more likely to answer those questions about intimate partner violence, about military sexual trauma. If you're on a screen, perhaps in a room with other people, perhaps with someone who might actually be causing you issues, you might be less likely to share that information. There's even that very large case that was all over the internet last week where that was actually a huge problem. So what we've done over the last year is to try to transition as much as possible through training providers on how to have those conversations through a telehealth sphere. This is new. This is a new space that we need to explore, but really increasing MST screening, IPV screening through telehealth so that we can make sure that we're connecting with them and potentially helping them share the information that's necessary so that we can really address their needs. Otherwise, we've seen increased video to home services, more than 785% for unique women veterans over the last year. So we'll continue to push the margin. Granted, a lot of, especially gender-specific care is very procedurally based. Maternity care, gynecology, that needs to be face-to-face. So it's about addressing our culture. It's about making sure they feel safe as they walk into our walls. And then if not, making sure that they have that coordination to go to those culturally competent providers in the community.
Thank you, Dr. Matthews.
Yeah, thank you, Congressman Mervan. I now call upon Congressman Rosendahl for 5 minutes of questioning. Also a new member of the committee, and welcome.
Hello, everyone, and thank you, Chairwoman Brownlee. And thank you, Dr. Matthews, for your service. Greatly appreciate it. Dr. Matthews, in the last Congress, VA declined to change the regulations governing the medical benefits package to add abortion as a covered benefit because, and I quote, VA believes that Congress, as the representatives of the will of the American people, must take the lead on this sensitive and divisive issue, and VA take no further action on the matter without a legal mandate. End of quote. Yes or no? Will the current administration keep that policy in place?
Sir, I'll have to take that one for the record. I don't feel comfortable speaking on behalf of the administration just because I don't know their current stance on that statement.
Okay, well, if you could please check that out. And if there is any deviation from the current policy, if you could report that back to this committee as soon as possible. Dr. Matthews, one aspect of the passage of the Deborah Sampson Act would require the VA to prioritize retrofitting existing medical facilities to make it safer and easier for women veterans to get VA care. What metrics do you have in place to track success or failure of these new programs or procedures?
Dr. Hayes, can you speak to retrofitting at all?
Certainly, I'd be happy to talk about that. The Women's Health, as Chief Officer, I'm very involved in helping facilities review what they need to do in terms of retrofitting the facility. We talk about walkarounds where the leadership has to walk around with women veteran and women veterans employees and talk about what's not working. And then the local facilities, women veteran program manager should be working with the capital assets manager to work up new plans. In addition, from a central office level, we are involved in what's called the SCIP process, Strategic Capital Improvement Plans, where my office has when those come in, which is very soon, there are literally hundreds of them, my office reviews with the SCIP board to make sure that the plans that are being submitted are appropriate for changes that will enhance the environment for women veterans. So sort of on the grassroots level and on the top-down level, we're very involved and invested in, and we've been looking at lists of recent projects that have improved, and one which was a big project this year was of interest was a mental health unit to improve the environment for women's health in that mental health unit. So it's the type of strategic improvement projects that we're looking for.
Okay, so Ms. Hayes, if you could then answer me though, what I'm trying to get at, or do we have, or are we planning to establish specific criteria, metrics where we can measure either wait times or new services that are offered or ease with which or expanded access to additional services so that we actually have measurable areas that we can show improvement?
Certainly, we have the access and all of those wait times by facility, by gender, by age, and by race and ethnicity. So we look at those. We're part of our, we have a matrix of measures to measure improvement, a dashboard. And we've been tracking that, and we're tracking it now. And we've been separating out the facilities that are particularly challenged, the lower performing areas, and going to them and specifically working with them on quality improvement projects so that their performance can come up. So we have it nationally, we have it by visit, and we have it by facility, and we have those measures and metrics available.
Excellent, excellent. Then I very well am probably going to direct my staff to see if we can look at the bottom 25 percentile or something like that and see what the problems are so that we can focus on the actual problems and make our efforts much more efficient and effective. Thank you so much. Chairwoman Brownlee, I would yield back the remainder of my time. Thank you.
Thank you, Congressman Rosendale, and I now recognize Congresswoman Underwood for 5 minutes of questioning.
Thank you, Madam Chair. I'm grateful that our subcommittee is holding this important hearing on such an urgent topic. I'm proud of the progress that our committee made to improve healthcare for women veterans last Congress, but we know there's significant work ahead of us, particularly on maternal mortality. The United States has the highest maternal mortality rate in the developed world and significant disparities for women of color, particularly Black mothers, who are 3 to 4 times more likely to die from pregnancy-related complications than white mothers. Some of the drivers of adverse maternal health outcomes can even be more prevalent in women who served. For example, 1 in 3 women veterans report that they experienced military sexual trauma, which is linked with risk factors for pregnancy-related complications. And that's why I'm proud to be the lead sponsor of the Protecting Moms Who Served Act, a bipartisan bill I introduced with Chair Brownlee and Representatives Gus Bilirakis and Brian Fitzpatrick, which is supported by the American Legion, the Wounded Warrior Project, the Disabled American Veterans, and more than 100 other veteran and health organizations. The bill would commission the first ever comprehensive study of maternal mortality, morbidity, and disparities in the veteran population, and it also supports the VA's Maternity Care Coordination Program. Although the VA medical benefits package includes maternity benefits, prenatal and postpartum care is typically provided in the community. To coordinate this care, the VA has established maternity care coordination programs as described in a VHA directive. My bill would codify the programs in that VHA directive to ensure that pregnant and postpartum veterans receive the highest quality care. Dr. Matthews, can you describe how the VA's maternity care coordination programs have helped to provide veterans with both the clinical and the non-clinical care and support that they need during and after pregnancy?
Yes, definitely. And I'm definitely going to let Dr. Hayes speak up as well. I think this care coordination piece is such the critical piece, as you already said, navigating between both VA from perhaps some other non-maternity care and the community, but then more importantly, the other services that we offer as far as the other social determinants of health, and particularly our mental health strength, as that's not often as equally available or worthwhile in the community. I think what we definitely saw, anecdotally, but what we definitely heard was the strength of the care coordination program, particularly during the pandemic, when there was so much unknown about how COVID-19 would affect a pregnant woman. So their questions in connecting with their providers, their questions about vaccination, which of course is still an ongoing conversation. These are really the strengths that they have a person who they can hone in on and who is there for them throughout their pregnancy and after. So Dr. Hayes, any other thoughts?
Certainly, and I want to make sure that that we agree with you, Representative Underwood, that looking at maternal morbidity and mortality is a very critical issue, and one in which we've already invested a significant work group and deep dive to be able to look at the cases over the last 10 years. We, in addition, we know that we could look back, but we have to look forward and prevent maternal morbidity and mortality. And one of the methods to do that is to work with our maternity care coordinators, who are individual care coordinators for each woman veteran, to track throughout her pregnancy, to call her at the very least once a month, to make sure that we're assessing for things like depression and anxiety, and not just postpartum, but we know that both depression and anxiety and post-traumatic stress disorders can be factors in her health throughout the pregnancy, and then follow her through her return to VA care postpartum. There is a maternity care coordinator at every facility, but we do want to enhance their role and to expand support for them. We do trainings for them. We have been very interested during COVID. In fact, we just recently drafted an additional letter to go out to encourage women who are pregnant to get the COVID vaccine, because we know that there is a lot of internet noise about why women should not. And so those are efforts, for example, in that bond and relationship. But we are concerned. We have as was pointed out already, a very diverse women veteran population with 44% women of color, and they become pregnant at the same rates. And so we want to make sure that every woman veteran has a safe pregnancy, from preconception care all the way through and long-term returning to VA care.
Well, thank you both. You know, I would love to see that data, that 10-year data, if it's something that you can share with us on the committee. It would certainly inform our work and hopefully be a support that we could submit into the record along with this bill. Thank you all for appearing before the committee today, and I'm happy to.
Thanks, Congresswoman Underwood, and thank you for your leadership around this important issue. And now I recognize Congresswoman Frankel for 5 minutes of questions. The Congresswoman is also a new member of the committee, and welcome.
Thank you, Madam Chair. I'm sitting in a phone booth and I'm really getting warm, but not just from the phone booth, which what I'm listening to here. So in 2018, 13,000 women were raped, which was a jump of almost 40%. Let's see, and most cases actually go unreported, so actually a lot more. My first question is to whoever wants to answer: when these women who are raped, and if they get pregnant, are they forced to have the child? Are they forced to have the child?
No, they are not. No, that is a decision for the woman veteran to make.
Okay, so my question is, as I think there's something like 174 medical centers and maybe over 1,000 outpatient centers. I'd like to know across the country what is available for women for access to contraception, what is available to women who find themselves pregnant and want an abortion. What assistance do they get, or what kind of counseling do they get, or assistance?
This is Dr. Hayes. Perhaps I can clarify the Code of Federal Regulations. Currently, VA is prohibited from providing abortion or abortion counseling. With regard to contraception, we have full range of contraception available to every woman and man who desires to engage in contraception as part of their own plan for their families or for having a family. And that's available through telehealth, it's available through our pharmacists, et cetera. I'm not sure that I've addressed your question exactly as you'd ask it.
No, you have addressed my question, and I'm getting warmer and warmer in this phone booth. And I could just say very strongly that I will fight as hard as possible to change that rule. Gagging healthcare providers, to me, is a medical crime. And I'm hoping that this administration will lift that gag so that when women have a question, a medical question, whatever it is, whether a man or woman have a medical question, they can be given an honest answer to that question. In regards to the clinics around the country, the medical centers, are you in a position yet to evaluate which of them have what we would call appropriate facilities for privacy for women, for access for reproductive care? Not only, let's say, contraception, but if they become pregnant, prenatal care and after birth care?
Certainly, we have data both on privacy, which we do a regular rounding walk once a month and more often as needed. I can certainly provide you with the number of providers that are at every site that do what we call women's health primary care providers. These are providers that are trained in women's health, including reproductive care and contraceptive care. We have these available at 90% of our community-based outpatient clinics.
So well, it's just because I want to be in a position where we can help you if it's necessary. Is there any further funding that's needed to accommodate these facilities to make them work better for these women veterans?
Certainly, a significant focus of the additional, what I just talked about as we call it the Women's Health Improvement Enhancement Program. Right now, a significant portion of that is focused on making sure we fill gaps in staffing and any gaps in equipment so they can buy exam tables that are better for doing gender-specific exams, and making sure that they have the right providers in place and the right nursing staff and social work staff, et cetera. So that's the focus of that initiative right now. And we can provide to you anything that you need with regard to how we're exercising that money. But we don't need more money right now. We need to be able to, as we said, urgently run these programs, get them in place and get the hiring. And we plan to do a significant piece of that this year before the end of this fiscal year.
That's very good to hear. And what about the facilities themselves? Do they need, are they set up in a way? I know, look, if a woman's going in, for certain, I think women going for reproductive care, they want to be in a private setting. Are the facilities set up in that way for that to happen?
Yes, we believe they are. We actually have standards. They have to make sure that there's a privacy curtain, that there's a lock on the exam room door, that the foot of the exam table faces away from the door so that it enhances the privacy and the sense of security for the person undergoing the exam. We regularly make sure that these things are in place by literally walking around. So we want to make sure those are there.
Thank you very much, Madam Chair. I yield back. Thank you very much.
Thank you, Congresswoman Frankel. And just for your information, with contraception, yes, it's available within the VA, but women veterans have to make a copay out of pocket. And unlike civilian women who under the Affordable Care Act do not have to have any out-of-pocket costs for contraception. And two, on the abortion issue, I have a bill on abortion counseling. I mean, I certainly believe it's against a doctor's Hippocratic oath not to be able to give counseling on abortion. And we're also working on a bill that a woman veteran would have the full array of reproductive rights within the VA, but this is an issue actually that the VA can change without a bill. So they have the wherewithal to change this policy from within.
Thank you, Madam Chair. I suggest that if there's no letter, that I will write up a letter, and anybody who wants to sign onto it will get it to the VA. I will take your direction.
Excellent. Thank you so much. So with that, there are no further questions. And so the first panel is excused, but I think it would be really great if at least one of you could stay to hear what all of the other groups have to say. And before you leave, I wanted to just say to Dr. Matthews and your team here, this hearing was about looking ahead, and your testimony didn't touch a whole lot on looking ahead on all of these things. I think the implementation of Deborah Sampson is going to be a lot of the work in the next in the next year. But I'd like to sit down with you at some point when we can take a breather here and have that discussion together in my office, or your office, either one. But I would certainly like to be able to do that. So with that, we will go on to the second panel, and I'd like to extend a warm welcome and introduce our VSO witnesses. We have Ms. Ashley Burns, Deputy National Communications Director of the Disabled American Veterans. We also have Ms. Patricia Jackson Kelly, President, National Association of Black Military Women. Next, we will hear from Ms. Jennifer Silva, Chief Program Officer, Wounded Warrior Project, where we are also joined by Ms. Lindsay Church, Minority Veterans of America. And finally, but last but not least, we will hear from Ms. Stephanie Goddess, the Pink Berets. Ms. Goddess, I understand you were joining us today from Texas, and we know that you have been, and your fellow veterans have been deeply affected by the recent storms there. So I'm very glad that you could join us. I will again remind our witnesses to please pause for 2 to 3 seconds before speaking so that the recording will capture all of your words. And please remember to do so when answering members' questions. Your written statements in full will be included in the hearing record without objection. So with that, I now recognize Ms. Burns for 5 minutes.
Chairwoman Brownlee, my fellow Marine and Michigander Ranking Member Bergman, Chairman Takano, and my other fellow Marine Ranking Member Bost, and members of the subcommittee. On behalf of DAV's more than 1 million members, those who have served and sustained wartime-related wounds, injuries, diseases, and illnesses, we thank you for the opportunity to appear today to discuss the continued need to address issues impacting America's women veterans. The Deborah Sampson Act stands as a landmark piece of legislation for women veterans, one many years in the making and for which we thank the chairwoman and members of the subcommittee for supporting. As we look toward the implementation of the provisions as a critical next step, and even as we recognize the evolution of the VA to better meet the needs of an increasingly diverse veteran population, gaps remain in benefits access and usage, as well as health outcomes for women, to include racial, ethnic, sexual orientation, and gender identity minorities within that population. As VA works to assess changing needs and improve the availability of services for women veterans, continuity of care is essential, particularly for those who must use community-based care. This usage heightens the need for VA to complete the modernization of electronic health records in order to facilitate efficient and effective communication between VA and outside providers without placing the burden to transfer information on the veterans themselves. VA maternity care coordination provides a seamless link between VA and community providers, and while it has proven highly effective in many cases, to include my own, a 2018 VA report showed that only 11% of VA facilities have a dedicated full-time maternity care coordinator. Another 2019 study found that nearly 1/3 of women veterans at VA reported problems accessing early prenatal care, including women with histories of depression, as well as some racial minorities. Women veterans often have conditions that put them at higher risk for adverse birth effects or health outcomes, and among rural pregnant veterans, provider options may be limited. To this end, DAV recommends further investment in and implementation of maternity care coordination programs. After serving honorably and sacrificing for their country, many disabled veterans, including DAV members, have reported struggles with infertility. While we believe it is important to continue researching how toxic exposures, PTSD, and other rigors of military service may impact fertility, it is equally important that we provide timely reproductive support for those seeking to begin a family now. DAV is pleased to support the Veterans Infertility Treatment Act, which would broaden the eligibility for assisted reproductive technology for veterans. Concerning residential treatment programs and alcohol use intervention, estimates show 1 in 4 women using VA healthcare engages in unhealthy alcohol use. Though the number of women veterans entering VA treatment programs is on the rise, they are still less likely to be treated for substance use disorders than their male counterparts. While we believe providing a robust array of treatment services and enhancing prevention and early intervention efforts is crucial to addressing this growing issue, especially among the newest generation of veterans. Madam Chairwoman, it is often within the intersections of minority groups that we find a need for improved data collection and research in order to identify and address disparities. DAV believes every veteran who has honorably served this nation is entitled to safe, welcoming, and dignified care that meets their individual needs. We are pleased to see that Secretary McDonough has prioritized this, initiating important steps to help promote inclusiveness and equity across the organization. However, a 2020 GAO report showed VA still lacks a standardized approach to collecting sexual orientation and gender identity data among veterans, potentially leaving critical gaps in patients' medical history. Sexual orientation and gender identity matter in healthcare. It is imperative for VA to expedite development and implementation of a mechanism for veterans to securely enter this information as soon as possible, and for VA systems to allow for extrapolation of data across multiple fields to identify tailored healthcare strategies that are both clinically effective and culturally aware. The Deborah Sampson Act did include provisions to address VA's ongoing issue with sexual harassment and assault, and various elements are currently in development, including bystander intervention training for veterans. But in order to create the cultural change we desire, we must also prioritize funding for these efforts at VA and provide the tools required to succeed. Madam Chairwoman, in closing, General Ann Dunwoody is quoted as saying, "The most important element is trust. Without trust in each other and trust in the institution, you will not be able to realize your vision." It is encouraging that we are all here working together in earnest to realize this great vision, to ensure that the VA can be the institution that women and minority veterans have faith in, an institution that does earn their trust, and an institution that will prioritize their needs now and in the future. Madam Chairwoman, this concludes my testimony, and I'm happy to answer any questions the subcommittee may have.
Thank you, Ms. Burns. And I think this is the first time you have testified in front of my committee. And so you did a terrific job. And thank you for being here. I now recognize Ms. Jackson Kelly for 5 minutes.
Good afternoon, Chairwoman Brownlee and Ranking Member Bergman. Thank you for holding this extremely important hearing on the onset of the 117th Congress. My name is Patricia Jackson Kelly. I'm National President for the National Association of Black Military Women. Prior to delving into the recommendation for policy improvement, I would like to reintroduce the National Association of Black Military Women to the subcommittee. NABMW was formed in July 1976 by a group of 21 Black women who were Women Army Corps and Women Auxiliary Army Corps members of World War II, the Korean War, and the Vietnam War. They gathered together to discuss the service of Black military women being lost because of them getting older and it not being documented. Since the initial convening, NBMW has established a strong national network of Black military women. I'm hopeful that the timing of this hearing is an indicator of how the subcommittee planned to prioritize women veterans in the 117th Congress. And I'm grateful for the leadership of the subcommittee and the full committee to get the Deborah Sampson Act signed into law. On behalf of over 2 billion women's veterans worldwide, I would like to thank the House Veterans Committee for your relentless efforts on the women's veterans priorities. I would also like to thank the subcommittee for the opportunity to share the collective thoughts, experience, and data of NABMW on issues related to women's veteran healthcare. Not only am I a veteran who retired after 26 years of service as a lieutenant colonel, I also worked and retired from the Greater Los Angeles VA Medical Center, where I served as the Women's Veteran Program Manager for 10 years and was instrumental in developing many of the initial programs for women's health. So today's hearing's topic is of great interest to me. Addressing the current healthcare situation, a growing number of minority women veterans have entered the military and are being discharged as veterans. The VA now consider women as the fastest growing group of veterans, but their issues are not being discussed as often. Women veterans faces remarkable different experience from their male counterpart when they transition from military. Black women serve in a far higher number than their civilian representation. Many of the minority community typical have a higher rate of chronic illnesses such as diabetes and high blood pressure. They need providers that are fully trained to help minority women who often do not have their healthcare needs properly assessed and addressed, especially reproductive, pain management, and mental health assessment and treatment. According to the 2018 report prepared by the National Center for Veteran Analysis and Statistics, minority women make up about 22% of the total veteran population. In 2016, Afro-Americans were 11%. The report projects a decrease in the overall veteran population from 18.6 million in 2016 to 12 and 19 million in 2040. However, the percentage of minority veterans will increase from 22 to 34%. So in summary, NABMW requests and concur with the following actions to be taken: mandating access to legal clinic at VA facilities for low-income veterans, reproductive treatment and education included in the women's health program, increase hiring and training, implementing forensic nurse and ombudsman position to assist special population across the healthcare system. Separate entrances to women's veteran and larger facility to reduce harassment, increase medical care for victims of sexual harassment and assault. Madam Chairwoman and Ranking Member, this concludes my statement. I'm happy to answer any question that the member of the committee may have.
Thank you, Ms. Jackson Kelly, and thank you for your long service to our country, both in the military and the VA health organization. So thank you for that. I now recognize Ms. Silva for 5 minutes testimony.
Thank you. Chairwoman Brownlee, Ranking Member Bergman, Chairman Takano, and distinguished members of the Health Subcommittee. It is a privilege to join you today for this discussion on the healthcare needs of women veterans. As a woman veteran and in my role as Chief Program Officer at Wounded Warrior Project, I have the honor of overseeing the delivery of more than a dozen direct programs to 150,000 wounded, injured, or ill post-9/11 veterans, nearly 25,000 of whom are women. I want to thank the members of the subcommittee for their diligent efforts to legislate on behalf of women veterans. During the 116th Congress, your committee worked tirelessly to finally see the passage of the Deborah Sampson Act, a major milestone in fully integrating women into the VA healthcare system. Wounded Warrior Project was proud to support this landmark legislation, and we are equally invested in ensuring its swift implementation. However, our collective work is not yet done, and as we transition into the 117th Congress, we look forward to working with you to continue this momentum. Just last week, Wounded Warrior Project released the findings of our Women Warriors Initiative, and I would like to again thank Chairwoman Brownlee for joining us in such an important discussion. This report represents a year's worth of research into the experiences, challenges, and livelihood of the women warriors we serve. Nearly 5,000 women gave their voices to this initiative, and their input firmly guides our advocacy and my testimony today. A full list of findings and recommendations are included in my written statement. However, today I'd like to highlight a few key issues for the subcommittee's consideration. First, we ask that the subcommittee continues its focus on expanding access to quality healthcare, as others have said. Despite their quickly growing share of the veteran population, women warriors still report higher rates of difficulty accessing both physical and mental health care when compared to male warriors. We can close this gap by increasing the availability of gender-specific care, optimizing alternative channels of care like telehealth and the community care network, ending harassment in VA facilities, and establishing a safe and welcoming environment for all veterans, as well as standardizing the quality of care in women's health clinics. Secondly, Wounded Warrior Project is focused on ensuring compassionate, comprehensive care for survivors of military sexual trauma, an experience which affects 44% of the women warriors registered with our organization. As you know, the ramifications of MST are wide-ranging and can impact a veteran's mental, physical, social, and financial wellness. These interconnected challenges must be addressed through an equally interconnected team. VA should take steps to increase collaboration with its agency partners, like the Department of Defense. Internal collaboration within the VA between care providers will streamline access to care and deliver a more coordinated approach to both benefits and to treatment. Finally, we believe more can be done to improve the transition process for women veterans. Setting up women veterans for success immediately upon separation from military service can help to avoid more serious downstream mental health issues and challenges. For women veterans, it is important to understand this concept in the context of isolation. 89% of Wounded Warrior Project's women warriors reported feeling isolated from others, indicating that social support is significantly lacking in this community. Their small share of the veteran population both underscores the need for and does present a challenge in creating opportunities for women veterans to connect. Physical distance also poses a substantial barrier. We recommend that VA take advantage of technological innovations to establish or expand peer support groups for women veterans in a virtual environment. Doing so will enable strong networks of support for service women who are transitioning to their new civilian identity. Virtual women-only peer support groups have been very beneficial in our own programming, and any efforts to remove barriers to care have been very well received by the women veterans we serve. As I come to a close, let me once again thank this committee for all your dedication to serving the women veterans who have served us all. Know that Wounded Warrior Project stands by as your partner in advocating for improved access and improved outcomes for women veterans across the nation. Thank you, and I look forward to your questions.
Thank you, Ms. Silva, and I will say to Dr. Matthews and Ms. Hayes that I've taken a hard look at this survey that the Wounded Warriors Project has done, and I would really recommend. It's very good reading, and I think it had 5,000 women veterans who responded to it, and a large percentage of the 5,000 were younger veterans, so it does give you a very good snapshot of what women in the military and women veterans are thinking about right now. So thank you for that. So I now recognize Ms. Church for 5 minutes.
Good afternoon, Chairwoman Brownlee, Ranking Members Bergman and Bost, and distinguished members of the committee. Minority Veterans of America works to create belonging and advance equity and justice for the minority veteran community, including veterans of color, women, LGBTQ, and religious and non-religious minority veterans. Our members account for thousands of years of service, some from conflicts and eras that predated their legal recognition as veterans. Just under half of our members identify as women. I would like to begin with recognition of and gratitude for the passage of the Deborah Sampson Act. This landmark legislation will have a lasting impact on women veterans for generations to come. As the fastest growing demographic within the veteran community, this rapid evolution has left a lag in institutional frameworks meant to support women after their service. We are grateful for this committee's concurrence that we must continue to center and prioritize their needs. Our military history hosts a culture of harassment and views that minority and women-focused bigotry is acceptable. Historically, institutionalized discrimination has been in place for decades before being addressed by agency or congressional action. This toxic environment inflicts lasting damage on our community's mental and emotional health. Women veterans fight for the validation that their male counterparts innately receive, only to face systemic limitations from an agency that, at its most fundamental levels, forgets, marginalizes, and even excludes them. A perfect example of this exclusion is the department's motto. It does not reflect the diversity of our veteran community nor our country. Due to their invisibility and inequitable access to care, women veterans are experiencing a rise in suicide rates and mental health crises, homelessness, health disparities, and more. The motto must be changed to make clear that all who have served are supported and welcome. Time is of the essence. Military sexual trauma has become a topic of national discourse. Those conversations have to date had no substantial impact on the rampant pandemic we are facing. The murder of Specialist Vanessa Guillen, the continued incarceration of Sergeant Teu, and the death by suicide of Sergeant Elder Fernandez illustrate the need for urgent cultural and structural changes. In a recent report reviewing 7,825 instances of military sexual assault, only 3.3% of all perpetrators were held to account, and 1.8% were required to register as sex offenders. those same perpetrators become patrons of the VA. These pervasive ideologies and practices tell our community that they cannot expect safety within the department's institutions. This burden makes women veterans aware in the worst ways that their bodies are hyper-visible and their voices are invisible. In too many cases, their stories include assault, violence, and trauma. This harm is compounded by the justified expectation that speaking the truth will lead to them being shunned or gaslit for putting their self-protective interests before community cohesion. The necessary trust and required confidence of the community has been broken, and our known and silent survivors are suffering. The department must take a proactive stance and establish a center charged with the protective role of sexual assault and harassment survivors. The VA must be laser focused on prevention efforts for the foreseeable future, focused not on legal liability, but on a deep commitment to truly better outcomes for survivors and women veterans. On the issue of family planning, the rate of unintended pregnancies for Latinx and Black women are significantly higher when compared to their white counterparts. Women veterans are additionally more likely to have an abortion when compared to non-veterans. Factors such as poverty, housing insecurity, and marital status further increase abortion rates. The Veterans Healthcare Act currently prohibits abortion services and counseling even when the pregnancy endangers the veteran's life, which increases out-of-pocket healthcare costs for the vulnerable communities and limits their reproductive freedom. Comprehensive and equitable family planning services, including abortion and contraception, IVF and surrogacy, are medically necessary fundamental human rights. We urge the committee to expand coverage to cover all veterans, regardless of the source of that need, marital status, or if the individual in need is the veteran or their partner. Lastly, we must begin taking a comprehensive and intersectional approach to data collection. The health outcomes for LGBTQ women veterans are unavailable because the department does not collect this information related to a veteran's gender identity or sexual orientation. Implementation of the Deborah Sampson Act was not the final step. There is more work to be done. Our suggested focus areas were developed with our most marginalized in mind, and I would encourage that future legislation be done in a similar manner. When a system is designed to serve those most sidelined, it will inherently be better situated to serve those that experience heightened privileges. Thank you again for the opportunity to submit testimony and for inviting us to the table for this conversation. I look forward to answering any questions you might have.
Thank you, Ms. Church. It's good to see you again. I now recognize Ms. Gaddis for 5 minutes.
Chairwoman Brownlee, Chairman Takano, Ranking Member Bergman, Ranking Member Bost, and distinguished members of the subcommittee. On behalf of the Pink Berets, thank you for the opportunity to testify on improving healthcare for America's women veterans. My name is Stephanie Gathas, and I am the Chief Executive Officer and founder of the Pink Berets, a nonprofit dedicated to providing aid and relief to women of the United States Armed Forces, both active duty and veterans who are seeking assistance with invisible injuries, such as post-traumatic stress disorder, military sexual trauma, and traumatic brain injury. The Pink Berets have served over 1,100 women veterans through our in-person programming and have virtually extended our services across the country and world. I sit before you today to testify from my own personal experiences as a woman veteran and service provider to women veterans on behalf of countless strong and resilient military women who find themselves silenced and disregarded. Despite the intentional silencing and marginalization of our community, women veterans persevere, adapt, and overcome. Through our work providing service to the military and veteran community, we are cultivating ways to enhance our scope of work through various program options. However, as this committee is aware, there is still a vast amount of work that needs to be done to provide the necessary critical support women veterans truly need. For the purposes of this statement, we have several key areas where the VA can and should expand services and programs to support women veterans beyond Deborah Sampson. These areas are women-focused mental health treatment centers, gender-specific housing and shelters capable of supporting military sexual trauma and trauma survivors, housing for women veterans with families, peer support programs, and increased access to mental health services and transitional services. As mental and physical health needs continue to arise, we are looking to the Department of Veteran Affairs to provide a higher level of care in our community. A story that illuminates the cracks in the system for women veterans is one of a recent Pink Beret clients from just this year. The story, like many, begins with a woman veteran grappling with a mental health crisis, homelessness for 3 years, And because of the nature of her illness, she was without a support system. I was homeless. I know the struggle. Dr. Denise Abney and I took her to the VA hospital on a Friday where she was examined for substance abuse and a possible manic episode. Over the course of the weekend, I received 7 different calls from 7 different providers who also could not help facilitate housing after the dismissal. I was told, I'm sorry, we just don't have enough resources for women veterans. The VA states they are working to change this. However, nothing has changed. She was still released on a Sunday because she seemed okay but refused treatment. I was now presented with a Herculean effort to find a suitable place for this woman veteran to stay since she was an MST survivor, and a homeless shelter was out of the question. Furthermore, placing a woman veteran in an environment once diagnosed with bipolar disorder and PTSD can also impede progress. I was contacted by several social workers who then worked with me to find her a place to reside. Ultimately, she was placed in a group home where I was told recently was offered to house a few women veterans since there was nowhere to place them during COVID. 1 week later, the woman veteran in question left the group home, once again homeless, roaming the streets with an untreated mental illness. How do we rectify the situation and allow this type of care to continue? The answer is not simple, but it will take all hands on deck to change the way we address mental health and homelessness in military women. The following recommendations are being made by the Pink Berets. Number 1, women veteran mental health day treatment programs. Implement a day treatment program that is designed to address all transition-related issues and instances where mental health crisis has not been identified. In the past, San Antonio's VA administered a day treatment program. This program was equivalent to the Laurel Ridge Treatment Center partial hospitalization program. This resource was closed in 2016, but still the resources needed, especially with OEF, OIF, O&D veterans who require transition services and more intensive care than veterans from previous eras. Creating a standalone center for women would increase utilization of VA services and boost confidence that the VA is working towards addressing the specific needs of military women. This space should be staffed with gender-specific peer counselors with experience providing culturally responsive and trauma-informed care. Women identified peer counselors. There's still a deep need for peer counselors who identify as women to be installed within the VA. Expanding representation for women veterans would rebuild the trust necessary to increase utilization by women veterans. This peer support specialist should receive mandatory training on providing culturally responsive and trauma-informed care. Coordination of care. Women veterans are getting lost in the system and being afforded care that does not take into account their unique lived experiences and to receive treatment for a myriad of reasons. To improve, VA must attend to the needs of patients who are diagnosed with a mental health disorder and refuse treatment. Coordination and communication between VA's Office of Community Care, community providers, and veterans themselves. The mechanisms are in place, but staffing and training are continually needed to ensure that the coordination of care for women veterans is seamless. The delay in care in this case was unnecessary, and the veteran was left to determine her own course of action. This wait and the unnecessary complication can be a struggle. Outreach efforts. VA must improve communication to women veterans by improving outreach efforts. Women veterans lack the knowledge of programmatic and service offerings at VA. This can be improved by targeting and dedicating outreach efforts to women veterans. A referral system for women veterans and how they can get available treatments through the VA and how the process would work for them to be referred from one program to the other. The referral process from VA to community provider or organization is difficult for women veterans to navigate and impedes their ability to understand how to overcome the obstacles that are laid before them. Dedicated women veteran funding. While there's a deep recognition that women veteran services are starkly behind the growth of this community, this emergency has not been met with funding mandates that require VA to invest in women veterans. Until this investment is made, we will continue to see these outcomes for our community. Successful programs require dedicated funding to ensure their success. Thank you again for
Ms. Goddess, I hate to interrupt you, but you're way over your time limit. I was hoping you would have enough time to conclude here, but I'm going to have to interrupt you. So if you just can make a few closing comments.
Yes, ma'am. We just look forward to the opportunity to work with you and your office to build an equitable support for women veterans. Thank you.
And thank you so much for your testimony. And we are looking forward to working with you this year. So I wanted to also make sure that all the statements are in the record, because there were many statements for this hearing, and I think it's just important to recognize that because of the interest of the topic of this hearing. So other organizations that made statements for the record are AMVETS, the American Legion, the Center for Reproductive Rights, the Coalition of Organizations Committed to Improving Reproductive Health Care Access for Service Members and Veterans, Iraq and Afghanistan Veterans of America, Modern Military Association of America, Paralyzed Veterans of America, and the Veterans of Foreign Wars. So all of those folks wanted to testify in our committee, but we couldn't have everybody testify in person, but it was important for people to know the interest in this particular topic. So I now will recognize myself for 5 minutes of questions. And, you know, my first question is, you know, to all of you here. But as I asked Dr. Matthews, the Deborah Sampson Act requires the creation of a VSO working group to be active participants in VA's effort to end sexual harassment and sexual assault. So I want to hear from all of you whether you've heard from the VA on this. They said that they are close to making this happen, but curious to know if anybody has been outreached to.
We have not heard anything, ma'am.
We have not either, but we're eager to work with them.
Very good. Very good. So anybody else, everybody else in the same, Ms. Silva, Ms. Burns?
Correct. We have not heard about the working groups, but we have worked with Ms. Jackson on many issues regarding the rollout of the White Ribbon Campaign, and she has sought feedback on the rollout of the bystander intervention training and things like that. So we have had communication.
Very good. Well, it sounds like Ms. Jackson will be reaching out to you soon. And I look forward to the work that all of you will be doing together. I think this question is for Ms. Burns and Ms. Jackson Kelly. So we're inching closer to a large wave of aging women veterans who will need home and institutional-based services to remain healthy in their elder years. Are the VA's current sort of home-based programs, such as the caregiver program and home-based primary care, sufficient to meet the needs of aging women veterans? And are women veterans more or less likely than civilian cohorts to enter an institutional setting for care? And I will add that the median age of veterans today is 51 years of age, so you can see where that's going in terms of elder care, our aging women veterans. Ms. Burns?
Thank you, Chairwoman Brownlee. So as far as the caregiver program, we know that obviously there are many changes that are undergoing right now within the comprehensive program. There are also many options outside of the comprehensive program. And I think one of the important things that we need to recognize is for those who are not part of that comprehensive program, we need to be outreaching to veterans and letting them know what options do exist as far as other caregiver supports are available to them. And I think that's kind of a continued theme that we see, is just making sure veterans do have that knowledge. I think there may be a gap there about what they are informed about may be available to them. I know that there are many programs and services within VA that do benefit older veterans, and making sure that they're able to remain in their homes and have that, that family support, which is incredibly important. And it prevents them from having to enter institutions where they may not necessarily be getting the care that they need, or as specialized care, or that family support. So we would want to make sure that as veterans are aging, that's a conversation that's being had with them, and that, you know, we're making that VA is making sure they are keeping them informed of their options.
Thank you, Ms. Burns. And Ms. Jackson Kelly, would you weigh in?
Yes. First of all, I think that the VA should do a better job of communicating with the community partners like AARP and the different organizations that do a lot of workshops when it comes to elderly care. Because I visit the VA hospital before the pandemic, and when I visit the nursing home, they only had 2 women's veterans in the home. So, you know, I found that quite astounding. But in the domiciliary area, they do have older women, but they are more or less geared towards a younger program, and they don't have anything to address the older veterans. So I think that education is a key factor here, and I think that we should do more community outreach.
Thank you so much. And my time is up. And so I will now recognize General Bergman for 5 minutes of questioning.
Thank you, Chairwoman Brownlee. Ms. Silva, I'm sure that, like me, the Wounded Warrior Project is very concerned about the impact that the pandemic has had on women veterans' mental health. Well, I hope the worst is behind us. What would you recommend that VA and Congress do better to better support women veterans during and in the aftermath of this extraordinarily stressful period?
Thank you, sir. I would say we've seen some silver linings in terms of the women warriors that we serve. They have really responded to the virtual offerings, particularly with telehealth, mental telehealth, and emotional support calls, and everything to our physical health and wellness workouts. And they represent about 17% of our population that we serve, but they are traditionally in these virtual offerings participating at a 44% rate. And so what they have told us in our roundtables that we had over the last year and in the survey, any efforts to reduce the barriers to care. So they didn't have to get childcare, they didn't have to drive. And so where you can reduce those efforts, this population of veterans is responding well to the virtual environment. And so I suggest, as Dr. Matthews mentioned, it's really a positive thing for the warriors. And they particularly, the isolation, as I mentioned, the 89%, we need to be really vigilant and over-program to this portion of the population of veterans because they need it. And in this time of physical distancing, that isolation is a key factor that we get concerned about. So I think that's really where the special sauce is for women veterans.
Well, thank you, because one of the silver linings, if you will, of COVID has been a better acceptance and outreach through telehealth for all of the kind of the needs that all veterans have, and that is a positive in this tough time. Ms. Burns, fellow Marine, and Michigander, do I get that right?
Absolutely, yes.
All right. Well, hey, then we won't talk in code here. We'll just talk in Marine, basic English. The unemployment rate among post 9/11 veteran women is roughly 9%. Before the pandemic, it was under 3%. I'm worried that the health impact that is having on women veterans. What more do you think VA could do to support those veterans who have lost their jobs over the last year?
Well, thank you for that question, General. Certainly that's something that we are very, very concerned about. That is not necessarily my portfolio. Employment services don't necessarily fall under my category. I'd be happy to take that question for the record and follow up with my team and provide some feedback for you.
Okay, thank you. Thank you. Ms. Jackson Kelly. Oh, I think she just walked away. Okay, Ms. Silva, one more One more here. I'm interested in your recommendations regarding a landscape study of women-specific healthcare resources. Would you be willing to work with the committee staff to develop that idea?
Yes, General, we're very supportive of that landscape.
Okay, great. Hey, Ms. Jackson Kelly, can you tell us more about the decade you spent as a woman veteran program manager at the VA Greater LA healthcare system? What did the frontline experience teach you about the needs of women veterans and the challenges they face that you think lawmakers like all of us should know?
I think that one of the things that you should know is that some progress has been made, but some of the things that we are revisiting now are the same things that I visited when I was there in 1981, which I find very frustrating because we seem to be reinventing the wheel. Some of the things that, for example, some of the things that we addressed with the mammography unit, they're still having the same problems now. Some of the things with the women being able to assess their healthcare readily is happening now. And we had developed what we call one-stop shopping in the women's clinic. The women were able to come to their appointment and on the same day get an appointment for their mammogram or get their lab work done. And sometimes that is not possible now. So I think that there needs to be more coordination of services with the other disciplines.
Okay, thank you very much. And Chairwoman Brownlee, I'm out of time. I yield back.
Thank you, General. I appreciate that. And I now recognize Congressman Bost for 5 minutes of questioning.
Thank you, thank you, Chairman. Hey, Ms. Church, just yes and no on this one, if you can. Do you think the VA is doing enough to vaccinate women and the minority veterans against COVID-19 at this time?
Simple yes or no. I think it's too, you can't really have a yes or no answer. I think the VA has been working as hard as it can and moving within the constructs of the COVID-19 pandemic.
Let me follow up then. The reason I was asking yes or no, because I want to know, what do you think the three greatest barriers are for VA vaccinating of those communities, and how do we identify the barriers?
To be honest, I think the VA's response in COVID-19 vaccination has been completely all over the map. The folks in Seattle are getting access to vaccines. Every single veteran has access. Here in Richmond, I have not received a call yet since the beginning of all of this. I have zero understanding. I asked a clinic person if they would be able to, I have respiratory conditions. They told me they couldn't even write for me to go get a vaccine. So I think that VA really needs to look at how are you making sure that what's happening in Seattle, which is awesome, is happening across the board, because there's so many folks that can't get accurate communication from their VA. So I think that's the one, but also trust building. We talk about this often, like the VA, if you're experiencing disparate outcomes when it comes to vaccines, it's because trust with VA is not there with minority veterans. You can't expect that folks are going to come in the door now after everything that's happened. So I think building trust and continuing to build those relationships, and I do credit the VA for actually trying. I have been really encouraged by the VA's response in trying to bring in minority groups over the last 3 months or so. So I do think that they are on their way, but I think there's a long way to go to building that trust back.
Okay, do you feel that that trust is every VA across the country, or is it just certain VAs?
I think it's based on the individual's experience. I think it's based on your identity. I think it's based on where you live. I think it's based on the facility. I know folks in Seattle that have great experiences when they're as minority veterans. I also know folks in Seattle, myself included, that had terrible experiences when it comes to VA. And the same thing here in Richmond, where I live. It depends on the person. And honestly, that's one of the biggest problems. There's no consistency. You'll have some folks that have a really great experience and love the VA, and some folks that, honestly, I could take it or leave it most days. I've had such a bad experience. So I think it's consistency of care. Like there are some VA facilities that are great.
And I know we're dealing with women's issues here, but I get that same response from both men and women veterans. Some either love it or you hate it. And it is the experience and the trust there. Ms. Jackson Kelly, you've testified that women veterans have, and I quote, remarkable different experiences than their male counterparts when they transition out of the military, and that's an end quote. What do you think Congress can do to make the transition process an easier and better one for women veterans?
I think that it has gotten better by the introduction of the TAP program being more strengthened. And I think that one of the things that we need to incorporate with this TAP program is childcare for the women, resources for childcare. Because I can remember when I left the military, I had a young son, and I did not have anyone to care for him while I was looking for employment, so it was a real challenge. So I think that one of the things that we need to do is incorporate additional resources.
Yeah, looking at your history, you left the military about the same time I did, and remember back then, I think that back then the answer was if they didn't issue you a family, you didn't have one. So I think they've got better with that, and I think the TAP program is vitally important. And if we continue to work with all of the people on this task force and these groups to make sure it gets better, and that we move them forward, not only DOD, but also the VA. And I want to say thank you to all the members here that have given testimony today. And Chairwoman Brownlee, with that, I will yield back.
Thank you, Mr. Bose. And I now recognize Congressman Sablon for 5 minutes of questioning.
Yeah, thank you, Madam Chair. I'm fine, 7.5 hours actually, but it's good. I thank you to all the witnesses, our witnesses. It is truly learning so much about an issue, subject that we're just beginning to touch. We're just beginning to address an issue that's overdue. But I'm going to direct my question to the Wounded Warrior Project, a project that I actually I'm very fond of. So, Ms. Silva, let me ask you, 32% of rural women warriors cited lack of resources in geographic area as a barrier to physical health care. So what can be done to increase access for all female veterans, including female veterans from such isolated geographical area like my district, the Northern Mariana Islands? I am 12 hours ahead of you. According to the 2010 census, there were 14,047 veterans living in the 4 insular area jurisdictions of American Samoa, Guam, the Northern Mariana Islands, and the United States Virgin Islands. The stateside proportion of women veterans was 7.2% in 2010 and 6.9% here in the Northern Marianas. While the number is almost the same, women in the Northern Mariana Islands do not have access to the same health services as their female counterparts statewide, way far off and different. So what can the VA do to improve access for women veterans in the Marianas? 1, and number 2, the lack of resources also prevent women veterans in the Marianas from accessing earned benefits. What can be done to address this discrepancy, especially among female veterans? Ms. Silva, please.
Sir, thank you for the question. That's really when we dove into our data, the disparity between rural women veterans and urban women veterans was the biggest disparity that we found. And as you mentioned, 32% called it a barrier to finding physical health or physical health care. And then it was even bigger. It was 42% of rural women veterans cited this as a top barrier for mental health care. And so, and that's double the rate of the urban veterans that answered the survey. And so rural healthcare is very difficult, and whether you're a male or female veteran, and particularly if you are an isolated, it could be in Montana, or it could be where you are, sir. And so we really think the landscape, to better understand the full landscape of care options, including VA-run facilities, if that's an option, unlike where you are, and then also community care network providers and DoD medical facilities and private civilian providers. The Section 203 of the Mission Act, and we're looking forward to that market assessment, and we'd like to use that data and be a partner in finding solutions for a better, more robust community care network that can really provide great care, whether you choose to live in a rural environment or urban, and then still the telehealth options should be an answer for some of that. I hope that continues as we get post-COVID, that we can use those lessons learned and develop a robust network for telehealth options for our veterans as well. That also will probably need to ensure that we have the technological network to support that as well. So that's what we see as the biggest area of concern, is the rural women veterans.
Right. Just generally, VA, look, when I got into this job in 2009, in late 2009, I actually stopped over at the Honolulu Regional Center and asked, there was completely no VA service in my district. But I was made aware that there is a contract that was negotiated, and it just stopped. The negotiation just stopped. So I asked then Dr. Hastings, I am out of time, but thank you everyone for what you do. I appreciate it. We'll continue to stay in touch and hopefully, move forward this very important topic that we're just beginning to touch upon. And with Chairwoman Brownlee's leadership, I have no doubt that we would make some strides in the next 2 years. The chairwoman and General Berkman, as a matter of fact, the chairwoman is right across from where my office right now too. So thank you very much. I'm going to turn my computer off. It's going on 8 hours. I started at 11 last night. So
we release you. We release you. We
We'll
release you, Mr. Sablon. And
we'll see you again.
We'll see you again. Thank you so much.
Thank you, everyone. Thank you.
Yeah. Thank you. I hope the panel knows that votes are sort of going on at the moment. So we've lost some members, but I had a couple more questions that I wanted to get in before I have to go and vote. And the first is, so, we've all concluded that we don't have enough data regarding the LGBTQ veterans. We know that transgender people are twice as likely to serve in the military than cisgender people, and that lesbian and bisexual women also serve at disproportionately higher rates. So if I could ask really all of you, what are your top two priorities? Just to limit it to the very top two in terms of next steps that the VA needs to take.
May I answer that one first? So first and foremost, Ms. Brownlee, you absolutely alluded to one of the biggest problems for LGBTQ vets in this data collection. We can't address health outcomes for veterans, for LGBTQ veterans, if we don't even know how many there are. We've been using outdated data for at least 5-10 years at this point, saying that there were 1 million LGBTQ veterans, despite the fact that this generation is more gender diverse and sexual orientation diverse than any other generation before. So we know that data is outdated. So that is like priority number one, because we can't see the outcomes of LGBTQ folks without it. Second is IVF and surrogacy. This is like the natural family planning for LGBTQ couples. We cannot plan a family without IVF and surrogacy, once we get to a certain point. So expanding that family coverage and being able to actually offer that to partners, being able to expand coverage to veterans who are not service-connected disabled. Those are things that are going to help folks like myself have a family one day. So those are the two things that I would hit on first.
Thank you. Ms. Silva?
Yes, ma'am. We recognize, I think we really need more data, as Lindsay just mentioned. We need that, and we have actually recognized that within our own population as well, that we need more data to support where our priorities are. We support forward-facing measures related to IVF as well. I'm just going to echo, I think that that's a really important issue as well that we've supported thus far.
Great. Ms. Gattas?
I echo what Lindsay was sharing earlier. It does come down to data. I think that's going to be a very important aspect, but I also think that we need to also look at support groups. I know that a number of the LGBTQ community has come to the Pink Berets seeking this type of service.
Very good. Thank you for that. Ms. Jackson-Kelly?
I agree with the fact that we need to be more data driven. But my second thing would be to find more minority providers. Recently, I have a Black nurse practitioner who I'm going to for my care, and it has made a world of difference. You know, it's true that you have to have walked in somebody's shoes to understand. And I just do not feel that the VA is doing enough to reach out to the minority providers to attract them.
Excellent. And Ms. Burns?
I would very much agree with everyone on the panel and the issues that they raised about data collection. And one thing I would add as well is looking to the Veterans Experience Office to actually host, if it's focus groups, and actually talk to veterans of minority groups to kind of extrapolate additional information about what's working, what isn't working, what is needed, and then kind of use that in concert with the data that we get and the research that we do to improve the care and services that we're providing.
Terrific. Those are all good suggestions, and I appreciate it. So, you know, before we conclude, I just wanted to ask Ms. Gattas. I know that she's from Texas, and Texas was severely impacted by winter storms, as we all know. And I certainly believe that women are disproportionately impacted by climate change and resulting natural disasters. So I was just wondering, Ms. Gattas, if you could share with us how many of your members were impacted by the storm, and how the Pink Berets came to their rescue and supporting them.
So we had a number of women that were impacted, whether it was their home and they had broken pipes, or their water power was turned off. The best thing that we could do was to help them get into a hotel that had the services that they were needing. So to have access to water, to have access to power. I mean, that was the greatest threat that we have, but we are still dealing with the aftermath. We still have women that are still trying to get things fixed. And so we're coordinating with different companies to try to get them the assistance they need to get their home back in order, because nobody was expecting something of this magnitude. And so, as you can imagine, we're extending, you know, the reach to other organizations as well, so that through collaboration, we can help them with the resources that are needed. But it was definitely an unforeseen weather, but the way that we stepped in was just to immediately place them somewhere where they could be safe, especially those that had families. And really to look to the hotels was really the first call to action for us.
Thank you so much for sharing that. And if we can be of any assistance to you, you know, please do reach out to us. So,
yes, ma'am. Thank you.
So General Bergman, I think, has left. He's probably on the floor voting. So I will close out this hearing. And I think the thing that strikes me the most, it's the good news and the bad news, I think, really. And the bad news is that we have a lot more work to do. The good news is that there's a commonality amongst all of these organizations in terms of what we need to be doing for women veterans. There's not any disagreement. So we just, we just have to roll up our sleeves and get to work. So because access to healthcare is a human right, it's clear that the VA healthcare system is the best place for women veterans with service-connected conditions and complex health histories, including military sexual trauma and combat trauma. We also still have work to do to ensure that VA remains a leader in conducting research and providing evidence-based treatment to our nation's veterans. Veterans frequently belong to communities who are already marginalized and face systemic and economic barriers to their health care. We must eliminate all of those barriers so that all veterans, including women, people of color, LGBTQ+, veterans and those living in rural areas, tribal areas, and U.S. territories have full reproductive freedom. Women veterans who wish to specifically learn about resources available to them can call or text the Women's Veterans Call Center. And for anyone who is listening, that number is 855 VA Women. Again, it's 855 VA Women. So I really do look forward to continuing this conversation. I already have I think a pretty good sense, and I think members on the committee have a pretty good sense of where we need to go. And I'm looking forward to, as I said in my opening comments, Secretary McDonough, I think, is very committed to our women veterans who have served and making these improvements that we're all talking about. And he's certainly committed to the Deborah Sampson Act. So we have good partners in all of this, and we can work together to get a lot done. So we will, between the Health Subcommittee and the Women's Veterans Task Force, we will be drilling down further on all of these issues to develop the legislation that we need. And so I thank all of you for your testimony and your commitment, and all of you for your service to our country and your continued service. And with that, this hearing is now adjourned.